Presiding.
Please be seated. Thank you.
All right, good morning, and let's go ahead and set forth our appearances for the record.
Your Honor, Will Kemp for plaintiff.
Good morning, Your Honor. Teddy Park on behalf of the plaintiff.
Good morning, Your Honor. Robert Eglin on behalf of plaintiff.
Good morning, Your Honor. Maggie DeFederico for plaintiff.
Good morning, Brianna Spitzer for plaintiffs.
Morning, Your Honor. Eric Peppermint, plaintiff.
Brad Johnson, Tyler Watson, Michael Esposito, and Eric Freeman on behalf of the defendants, Your Honor.
All right, once again, good morning.
Good morning.
It's my understanding our first witness from the defense perspective will be by videotape, is that correct?
That's correct, Your Honor.
2 hours?
Correct, Your Honor.
All right.
Your Honor.
Mr. Peppermint.
We didn't discuss it yesterday, but given the tight schedule between all the closings, we ordered lunch for everyone to be brought in at noon to include the jury, the court, and all counsel, just so it gives us the option of potentially having a short lunch so we can keep things moving today. So I just wanted to make the court aware of that.
All right. And so when you say keep things moving, Mr. Peppermint, what are your aspirations for today?
Yeah, Judge, I would hope we could get this testimony in. Dr. Alcina break for lunch at 12:30, 12:40. Resolve the one outstanding issue on the jury instructions, which is pretty minor. Resolve the verdict form and start the process hopefully at 1:45. Maybe you'll read the instructions and we can start the closing arguments.
Our position is, Your Honor, we still have an outstanding motion with directed verdict on the,
Oh, okay, yeah, you're right.
we have to argue that as well.
Okay.
Judge, I would hope that could be relatively brief since they've argued it 3 times already.
I understand, they have to make the record. Okay, so, in listening to that, I guess the first and foremost thing we should do is get the jury in and we can start the video.
Yes, Your Honor. Thank you.
Okay.
Do you have any exhibits that we need to discuss for this?
They're taking a look at some, no, not for this. And then for the remainder, we're working with them to find stipulations.
Okay, that's fine.
And we got a change in like 2019.
Yeah, the national title certificate.
Yeah.
Thank you, brother.
Yeah, testing.
Step down for
This
one
morning
second.
was crazy. I told you we'd have to find, that was one thing.
All rise for the jury.
Their tire was low. The tire was low.
Yes, Your Honor.
Busy morning.
Please be seated. Thank you.
Then I go.
You start getting the low cal ones.
Nah, I think the sugar helps.
Sugar helps. Good.
All rise.
Please be seated. Thank you.
All right, do the parties stipulate to the presence of the jury?
Yes, Your Honor.
We do, Your Honor.
All right, ladies and gentlemen, I just want to say good morning to you.
Good morning.
All right, and it's my recollection, we're continuing the defense case in chief, is that correct? Mr. Johnson?
Yes, Your Honor.
All right. And so the next witness will be testifying by videotape?
That's correct, Dr. Alsina.
Dr. Elson.
Hello, Dr. Alsina. We're here today to conduct your trial deposition. You understand that? Yes. Okay, great. And Dr. Alsina, go ahead and move to the second slide. Could you please just tell the jury a little bit about your professional background?
Okay, I grew up in Puerto Rico, went to college in Boston, went to medical school in my hometown of Boston. Then after that in '87, I went to Boston to train. I became a general surgeon at St. Elizabeth's Medical Center. And then after that, in between doing a couple of years of research in Hartford, I did research in transplantation. I did a transplant fellowship. I did a Deaconess Harvard program. I was a trained in body surgery. So I finished in '96, and I've been I spent my whole career in Tampa in the liver transplant field. So I've been there for 20-something years. Until 4.5 years ago, I'm a fellow of the American College of Surgeons. I'm a fellow of the Liver Society of Hepatologists. Only 8 surgeons are designated that way, so it's kind of rare, but I had a lot of interest in hepatology in my career early, and I did some contributions, so that's sort of a unique. I'm sort of like a hybrid surgeon, hepatology guy, in terms of how I conducted my career. I did a lot of research in terms of, research means industry research. I was an investigator in 20-something trials in even things that were not in transplant, like hepatitis C. I was one of the couple of surgeons that participated in the hepatitis C treatment trials of advanced cirrhotic patients for a drug that actually were approved. I did trials in very pivotal immunosuppression trials in liver. So some of those drugs were approved for immunosuppressants. And the oncology trials also, trials of liver cancer that I brought to Tampa General, and I conducted them, and a bunch of other kidney trials and things like that. But most of the ones I did were in liver, some of them were in NASH actually. In non-alcoholic steatohepatitis, NASH. And I have some publications in the fields of liver transplant, liver failure, portal hypertension, liver oncology. Most of my presentations were basically on the things that I used to do. I managed a lot of transplant patients in my career, over 1,500 liver transplant patients that I helped transplant and take care of, and manage immunosuppression and more than that.
And where do you currently work?
I work at the Veterans Administration System of Bay Pines VA healthcare system in Florida. Been there for 4.5 years.
Okay. And are you enjoying that work?
Yes, I enjoy taking care of the veterans, and it's pretty unique.
Great. And where were you before you were at the VA?
I was in Tampa General Hospital, academic center, 1,300 bed teaching hospital in Tampa.
Tampa General Hospital.
Correct. And
At the General Hospital, your accent, you're talking really fast.
Tampa General Hospital, and that's a big transplant center historically.
Great. And prior to this case, have you been hired as an expert?
Yes, I have.
Okay. And approximately how many cases?
How many cases have I been an expert in? Let's say over 50 cases.
Okay. And in what areas have you previously provided expert testimony?
Areas of drug injuries, areas of liver causation, areas of surgical injuries, some big liver transplant cases that I've done, surgical complications, causation of liver, life expectancy of liver patients, that sort of thing. Very varied caseload.
And in those approximately 50 cases or so, did you do work for the plaintiffs or the defendants?
For both. Heavily on plaintiffs too.
All right, well, let's go ahead and move to slide number 3. Now, as the jury is well aware, several medical experts have already testified as to the medical terms and concepts, so we're going to go ahead and spare them hearing that for a 4th or 5th time. But I do want to understand this particular slide that you prepared. Does this slide indicate that 10% of drug-induced liver injury patients develop chronic symptoms?
Yes, Mr. Watson, this particular study by Hayashi, who's a prominent hepatologist that's currently at the NIH, he wanted to know what the chronic patients with drug-induced injuries, how they had done. All right, so they looked at whatever they had in their daily network, in their network of drug-induced liver injury network in the US, and they were able to find, in their particular case series, 12% were chronic. These were patients that they never resolved their injuries. They had some biochemical abnormalities or something was wrong with them, that they deemed them chronic. They were not sort of resolved and normal. And then they also quoted a couple of articles there from Sweden and from Spain. They all had different rates, but the overall rate of chronicity of patients that have had drug-induced injuries that survived the events, that were not getting in trouble early, was about 10% that had a protracted course.
Dr. Alsina, when we went off the record, we were talking about slide number 3, which relates to a study that you cited in your expert reports. Is that correct?
Yes.
Okay. Can you explain to the jury where this information is coming from? I believe it's the last bullet point on this slide.
Yeah, it came from Dr. Hayashi in 2018, current hepatology journal. And it's a unique article that talks about the chronicity of these patients.
Okay. And does this conclusion from this article, is it that 90% of drug-induced liver injury patients do not develop a protracted or ongoing injury?
Yes, I mean, they found 10% had a protracted course.
Okay. And so with that, let's go to the next slide. In this case, you were hired to form opinions on the prognosis of these 8 plaintiffs, correct?
Yes.
Okay. And did you in fact form opinions on these plaintiffs?
Yes.
Did all of these plaintiffs suffer from a drug-induced liver injury?
Yes.
And did any of these 8 plaintiffs develop a severe or chronic course?
Yeah, they're all different. I mean, we could talk about them specifically. A couple of them behave a little bit different than the other 6.
Okay. Who were the 2 that developed a chronic course?
Mrs. King and Mrs. Bordenave developed autoimmune hepatitis, which the other ones did not have.
Okay. And for the remainder of the plaintiffs, were they part of that 90% that did not develop a severe course?
You can say, yeah, we're going to talk about each of them specifically, but they don't have any chronic protracted clinical course that we can identify.
Okay. And in forming your opinions, did you review any materials?
Yes, all their medical records and their pathology and x-ray reports and all the information that was provided to me.
So let's move on to the next slide. We'll begin talking about plaintiff Lisa King. Did Ms. King suffer a drug-induced liver injury?
Yes. When you say drug-induced, we're talking about a toxin in these particular cases.
Okay. And is that the only condition she contracted?
But she also developed autoimmune hepatitis. Autoimmune hepatitis in addition to the liver injury, which was, a severe hepatitis, but she developed an autoimmune process.
Okay. And so part of that autoimmune process was autoimmune hepatitis?
Yes.
And the other part of that was myasthenia gravis?
She also developed that too.
And we'll get into that in a minute, but first, why don't you take the jury through what her relevant medical history was from the years 2017 to 2018.
Okay, this is a concise view of everything because we're concising, everything. Otherwise, my report has all the details. But in 2018, she developed GI symptoms, gastrointestinal symptoms, and she had elevation in her liver function test and quote hepatitis. In other words, she had elevation of her transaminases and
You need to slow down a little.
yeah, she developed elevation of her serum transaminases, and then by September they had normalized.
Okay. And then if we go to the next slide, what significant happened to her medically in 2019?
In 2019, she had a transient, persistent elevation of her liver test, depicted there, transaminases in the 300, 500 range. She had a normal CT scan of the abdomen. In the summer, she went to Mayo Clinic to see a hepatologist named George Rakela, Rakela, and she went back home, was admitted at Summerlin Hospital in June, given some steroids. She was given steroids throughout many of these months and years for different other reasons. But she remained with persistent elevation of her test in the summer of 2019. In August, they were sort of near normal again, so she's kind of fluctuating.
So that should take us into 2020, where we would go to slide number 7. She did have an ultrasound in August. What was the result of that ultrasound?
Yeah, the ultrasound showed a homogeneous liver, meaning the echogenicity of the liver is sort of normal, non-fatty, based on an ultrasound. And then she was followed by a GI doctor named Dr. Zimmerman, who ordered a liver biopsy, which was done in September.
Okay. What were the results of that liver biopsy?
It was basically called a quote mild chronic hepatitis. It was not very descriptive. Not much was done there until she saw Dr. Gish at Loma Linda, Gish, Robert Gish. So she went over there to see an expert hepatology opinion.
So let's go ahead and move on to some treatment with Dr. Gish. We move to the next slide.
And if we look at the previous slide, Mr. Watson, she had a degrading of inflammation there as grade 1, which is a sign of inflammation because they're seeing some inflammatory cells and stage 1 fibrosis.
All right. Now let's go ahead and go to some more of this 2020 treatment with Dr. Gish. Did Ms. King in 2020 have a fibroscan?
Yes, she had one in October, which is a non-invasive test of fibrosis. Showed fibrosis in the stage of F0 to F1, so early, no cirrhosis. And she had a test in November 27 that her liver tests had normalized there, AST 20, LT 24.
Say that again, please.
There, in November 27, her AST was 20 and her ALT was 24.
And what did Dr. Gish note about Ms. King's condition on December 1st?
Well, on December 1st, that was about 5 weeks since he had started a medication called URSO, to treat her autoimmune hepatitis. And by that point, her tests had normalized. She was having no side effects from the medication. Mrs. King understood her diagnosis of an autoimmune process. And he also didn't think she was gonna need any more advanced medications, advanced immune drugs, because she had responded, her liver tests were normal, and he wasn't gonna recommend any other medications at that point.
And do you agree with the course of treatment that Dr. Gish prescribed?
Yeah, I agree, she responded. This is a condition that doesn't have very strict guidelines in terms of how to treat, when to treat, what steroids to use. And he decided to use this particular medication, which is, like an immune modulator. It's a biliary type of drug.
And it worked well for her?
It did.
If we move to slide 9, now we're into 2021. Is this when a biopsy from September 2020 was reviewed?
Yes, it took him a little while to get the biopsy reviewed at Loma Linda. I mean, by that point, Mrs. King already had been treated, but he wanted to review it formally, and that didn't take place until February. And, the results are there. They did not see any abnormal fibrosis. important findings are that the hepatic architecture remained intact.
Let me stop you there. What does it mean when the hepatic architecture is intact?
Well, that means that the framework of the liver, is intact, it hasn't collapsed, like in cases you would see with acute liver failure. And there was still some areas of inflammation there noted, which is what is seen in patients with autoimmune hepatitis. So this was a diagnosis, it was an autoimmune process, and that's what they confirmed.
And what is the significance of the pathology report comment near the bottom where the pathologist says the changes are not specific but could represent, you see that section?
Yeah, the changes could represent a quiescent phase of autoimmune process. I mean, they concluded that it was consistent with autoimmune hepatitis. That's my interpretation.
Okay.
And that was already decided by her specialist anyway.
So continuing on in 2021, we go to the slide 10. What other meaningful developments occurred in 2021 as it relates to Ms. King's medical treatment?
Okay, 2021, Dr. Gish either saw her in person or remotely. No changes were recommended. Her liver function tests on February 24th were normal. Good clotting, normal albumin. I mean, pretty much everything that he ordered was normal, as depicted there.
Great, and what about 2022?
2022, she had a liver ultrasound showing again homogeneous liver. Liver function tests were normal at the end of 2022.
And what about 2023?
2023, they remained normal in two time periods that were ordered in February and May. They were normal.
And have you had an opportunity to review some medical records that were disclosed in this case relating to February 2025 treatment?
Yes, Mrs. King was admitted for about 3 days with her exacerbation of myasthenia gravis. And there were some brief records that I was given. And actually her liver test remained normal at that point. That was about 3 weeks ago. 4 weeks ago, to clarify, to be more precise.
Thank you for that. So let's look at your conclusions. Can you explain what you found on slide 11?
Well, in slide 11, in my opinion, this quote hepatitis began a while ago in March of 2018. That's when she had the first elevation. She was being followed for months after that. She had no fatty changes described in her biopsy.
What's the significance of not identifying fatty changes in a biopsy?
Well, I mean, back then she didn't have it. She doesn't probably seem to have it now. She didn't have it before the injury, so it's significant that she doesn't have another problem to be concerned about. So it is favorable that she doesn't have a fatty liver.
And then next, you identified that after starting URSO, her LFTs normalized. What's the significance of that?
Well, it was kind of promptly with a drug that's not strong. It's not a corticosteroid or an immune drug. So she responded quite quickly.
And what was the URSO used to treat which of her conditions?
The autoimmune hepatitis.
Next, let's look at the first two bullet points on the next slide regarding Ms. King's autoimmune hepatitis. What are your findings there?
Well, she had, again, early response to URSO, no steroids, no Imuran, no advanced drugs. So no URSO, no Imuran, IMURAN, Imuran. No advanced immunosuppressants, were used in her case, like Cellcept, Cyclosporin. She's a patient that did not present with a severe acute liver failure type of picture. She doesn't have a fatty liver. So those are the conclusions of that slide.
Okay. And could you talk a little bit more about that third bullet point? I know you said there was no acute liver failure, but what else is contained there?
She does not have cirrhosis, which is good. She didn't have it back then.
And tell me about the fourth bullet point. What's the significance of these risk factors for NASH?
She doesn't have a fatty liver or any signs of fatty liver inflammation, something that can get her in trouble, independent of any autoimmune hepatitis.
And again, looking at the last bullet point, you approve of the use of URSO in her treatment?
I mean, I don't disapprove it. Dr. Ish knows what he's doing. He's very prominent and he uses it and it worked for her.
And the final slide for Ms. King. Let's look at the first 3 bullet points, which discuss the potential for a liver transplant in the future. Can you talk about that?
Yeah, I mean, that should not be in the discussion. She's not a patient that is headed for a transplant, has no advanced fibrosis, no cirrhosis, no recurrent episodes of, hepatitis or relapses. So it's something that doesn't really apply to her.
Okay, great. And based on everything that we've gone over, if you look at the 4th bullet point, did you reach a conclusion?
I don't think she's gonna be in acute liver failure in the future from a relapse of hepatitis. I think that would be unlikely.
As it relates to the course of treatment for MG and AIH, is it your opinion that those should be determined by her treating providers?
Yes.
Okay. In your opinion, though, she does have 2 autoimmune diseases?
Yeah, autoimmune hepatitis and the myasthenia are both autoimmune diseases.
And will both of those require monitoring in the future?
Yes.
All right, have you formed any other opinions as it relates to Ms. King?
No.
Okay. Then let's go ahead and move on to Ms. Bordnave. On slide 14, tell the jury about Ms. Bordnave's medical condition in 2018.
Okay, in 2018, on February, she went to the ER at Dignity Health with vomiting and abdominal pain, jaundice, elevated serum transaminases above 2,000, and the doctors over there thought that she had a biliary type of problem, and they transferred her to Mountain View. And she ended up being transferred to Centennial Hospital on February 26th because they needed special biliary type of studies that were not available at Mountain View, so she ended up being transferred.
All right, then let's move to the next slide. Can you tell me about those first 2 bullet points that relate to a March 6th treatment of that year?
Yeah, the biopsy was done on March 6th. We showed a moderate lymphocytic infiltrate, plasma cells, liver cell necrosis, and some cholestasis or some degree of bile duct plugging. And there was a differential drug-induced injury, infections, early autoimmune hepatitis, or bile duct obstruction.
And did Ms. Bordnave undergo some treatment with a Dr. Han, H-A-N?
Yeah, but before that, she was transferred to Southern California to USC Keck.
And that's where she received the treatment with Dr. Han?
Yeah, she received treatment there with steroids. Dr. Han is a hepatologist, and she improved, and she was eventually discharged, but then she was readmitted she was in the ER later on March 14th and transferred back to USC.
And if we go to the next slide, what happened over the rest of 2018 as it relates to medical treatment for Ms. Bordnave?
They reviewed the biopsy at USC on March 20th, and they said that she had no necrosis or fibrosis, but they started her on an immune drug called Imuran. It's an immunosuppressant, in addition to the steroids. By April, her liver tests were near normal and ALT was still elevated. ALT was still elevated at 43. And by July, they had normalized.
What about in 2019, if we go to the next slide?
Before that, she came off Imuran by that summer, but she let's go back one slide, Mr. Watson.
Sure.
By August of that year, she came off corticosteroids and she remained on the stronger immune drug, Imuran.
And what's the significance of that, Dr. Alcina?
Well, they wanted to use that drug for maintenance immunosuppression so that she could be treated and prevent any relapses.
So does that switch off steroids onto Imuran represent an improving condition?
No, that's what they decided to do. That's what her management was.
Understood. Now let's go to 2019. Can you explain the September 19th note regarding AIH being in remission?
Okay, in 2019, her liver tests were normal in January. On August, she was in an urgent care with GI symptoms, liver tests were normal. In September, her GI doctor, Dr. Faris, noted that she was in remission of autoimmune hepatitis, but she's still remaining in Iran. And in October, she had an ultrasound that measured liver stiffness, and she had no fibrosis according to that particular test.
Okay. Is that a test that you view as reliable?
Yeah, it's a test that's used commonly in the GI and hepatology fields to measure how stiff the liver is in situations where you would not do a biopsy.
And what about 2020? What happened as it relates to Ms. Bourdain in that year?
In 2020, she had normal liver function tests in February and in December. They were normal.
And what happened in 2021?
In 2021, at the end, in the fall of 2021, in September, she came off Imuran. And 3 months later, her liver function test and clotting remained normal.
And so based on that, if we go to slide 18, what conclusions did you form as it relates to Ms. Bourdain?
Mrs. Bourdain sustained a hepatocellular type of injury originally in February of 2018. She was treated with corticosteroids at USC. She had a biopsy there. She was diagnosed with autoimmune hepatitis. She was given corticosteroids and then Imuran or isothioprim. And by April, prednisone was tapered off. And by September of 2021, that's about 3 years later from the episode, she came off Imuran.
Great, and so tell me a little bit about her prognosis in your opinion.
Well, she has been off immunosuppression for 3 years. Her prognosis is good. And she has normal liver function tests.
Okay. Do you have any opinions on whether she's likely to suffer a relapse of her acute liver failure or AIH?
I mean, I don't think she's going to, she's not very likely that she's going to sustain an acute liver failure episode. And she's gone several years without a relapse, so, not too likely that she's going to have one.
Okay. And as it relates to her AIH, will she require monitoring in the future?
Yes, for life.
All right, let's go ahead and move on to Ms. Van Buren, slide 19, please. What happened with Ms. Van Buren's medical treatment in 2020?
Van Buren presented in November of 2020 with acute liver failure, confusion, encephalopathy, jaundice, a lot of the terms that everybody has heard of, clotting disorder, bilirubin of 11, high serum transaminases, high clotting test. She was given steroids and she was discharged a few days later.
And towards the end of the year 2020, did the bilirubin results come back down?
By December, her bilirubin was 1.1.
Is that within normal limits?
Yeah, that is.
Okay. And what happened in 2021?
2021, in September, her liver function tests were normal, and they were also normal the next year in 2022.
Perfect. So let's go to the next slide and tell us a little bit about your conclusions that you reached as it relates to Ms. Van Buren.
Ms. Van Buren sustained an acute liver failure episode from hydrazine, and she was treated with corticosteroids. She resolved within 5 weeks. Her liver tests have remained normal up to 2022, and I think she has a good prognosis.
Okay. Moving on to Ms. Diaz, slide 2021. What was her condition in November of 2020?
Okay, this is Vania Diaz in 2020, presented to Henderson Hospital on November 12th. She had neurologic symptoms. She was discharged. She went back again. She had a fatty liver on a CAT scan. Noted, her GI doctor was Dr. Saud. Noted transaminases above 2,000. High clotting test, INR elevated, low glucose. Her clotting tests were abnormal. She also had a low glucose. She had some affected kidney function, and she was diagnosed with acute liver failure.
And tell me about her discharge in November 17th of 2020.
Well, she was discharged with a bilirubin of 1.7. Her liver tests were still abnormal. She had a biopsy done prior to discharge, and the results came back later after she had been discharged.
So at the time of discharge, were her test results back to normal?
No, they were not.
Were they improving?
They were abnormal still. They were, improving in terms of the jaundice. If she was discharged, then they were better.
Understood. If we move to slide 22, what were the results of her November 2020 biopsy?
A couple of findings there that are noted: intact hepatic architecture, but she did have a lot of fatty change, moderate to severe fatty change of the macro and micro type of steatosis or fatty change. So the two types of fatty change were noted in the liver cells. Portal tracts were not inflamed, the lobules of the liver were not inflamed, no fibrosis was seen according to the hospital records.
Okay, in your opinion, what's the significance of these findings?
Well, this is consistent with some of the injuries that we saw from hydrazine in terms of the severe fatty change. It's good that they did not see any fibrosis according to the hospital pathologist.
And moving to slide 23, what else happened with Ms. Diaz's treatment in 2020 and moving on to 2021?
In 2020, at the end of December, in December, her liver tests were normal. In 2021, she had a FibroSure test for fibrosis, which showed no fibrosis or inflammatory activity, F0, A0. And in April of 2021, that's the next year, that's the same year that the FibroSure was done. In April, her liver tests were normal.
And if we move to the next slide, based on what you've gone over as it relates to Ms. Diaz's medical treatment, did you reach any conclusions?
Mrs. Diaz developed acute liver failure. Mrs. Diaz test normalized after December of 2020. She had severe fatty change back then. She had no fibrosis on testing in 2021. And I think she has a good prognosis.
And what do you mean by a good prognosis?
Well, she hasn't had any problems since. And she did normalize her test. She had a prompt recovery from that severe injury that she had back then.
Okay, what does that mean for her moving forward?
It's good that she doesn't have any active problems now.
Okay. In your opinion, will she sustain an episode of acute liver failure in the future as a result of her prior exposure to hydrazine?
Assuming she's not going to be exposed to hydrazine again, she should not sustain an episode of acute liver failure. We don't expect her to be exposed to hydrazine again, so that's what I mean, that it's unlikely that she's going to have some sort of relapse of acute liver failure.
Now let's move on to Ms. Chang. What was her medical condition in late 2020?
Mrs. Chang, in November of 2020, was admitted to St. Rose Dominican St. Martin campus with GI symptoms, incoherence, confusion, jaundice, high clotting test, elevated serum transaminases, and her CAT scan of the abdomen showed a fatty liver, no abdominal findings in her chest. She had an ultrasound also which confirmed some fatty infiltration changes.
And the next event that occurs appears to be in early January of 2021. What happened there?
She was seen by her GI doctor, Dr. Karan, K-A-R-A-N-P-H, and he noted that she had resolution of the abnormal liver function test. By the end of 2021, her liver function tests were normal.
And finally, what about 2022?
In 2022, she was in the ER at St. Rose Martin. Normal liver function tests were noted at that point.
And based on your review of these medical records, moving to slide 26, what conclusions, if any, did you reach?
Mrs. Chang also sustained acute liver failure. Her liver test normalized within a week of presentation. She's 4 years out from the acute liver injury. I think she has a good prognosis.
And what will that mean for her likely in the future as it relates to a potential relapse of acute liver failure?
As long as she doesn't get re-exposed to hydrazine, then there's no reason why she should have an episode of acute liver failure again. She had a toxin type of injury that has been withdrawn, so That's what we would expect, or I would expect.
Thank you, doctor. Moving to Mr. Davis Richard, starting in late 2020, what was Mr. Davis Richard's condition?
Mr. Davis Richard, in October of 2020, presented to Centennial with elevated serum transaminase. It's not that high, 78, 92 range. He was seen by his GI doctor, Dr. Giuliani, on November 6th, again with more GI symptoms. Liver tests were normal in February of 2020. In October, transaminases were elevated, again, 78 and 92 for AST and ALT respectively.
Looking in that December 14th note, was his bilirubin level normal or elevated?
Well, before that, he was in the hospital in November at University Medical Center with elevated bilirubin, serum transaminases, some neurologic symptoms there, tremulous hands, and he was discharged. And these tests remained abnormal through September. Bilirubin was high, 2.6, serum transaminases were high, 266, 498. And he was also confused, and his doctor, Dr. Magnus, treated him with lactulose for encephalopathy. With lactulose, Lactulose. So he treated him with a medication to treat hepatic encephalopathy.
Okay. Now let's go to that December 14th note. What were the results of the bilirubin test?
Bilirubin was one normal with transaminases were near normal but not normal altogether.
And if we move on to the next slide, this will take us to 2021. In January, were his levels back to normal?
In January, they were normal. January 15th, bilirubin and AST and ALT that are depicted there were normal. He was no longer on lactulose according to the records. In March, the liver function tests were normal, so were they in June and in August of that year. And they were also repeated in September and December, and they were normal.
And did that carry through to 2022?
Yeah, just twice they were checked in 2022 in April and June. Bilirubin transaminases and the liver tests that were done were normal.
And based on those records that you reviewed, did you reach any conclusions as it relates to Mr. Davis Richard?
That's on the next slide. Mr. Davis Richard sustained, the word liver failure was not in the medical records, but his doctor treated him for encephalopathy, so I just want to clarify that. Transaminases peaked in November 13th of 2020. He had a significant hepatocellular type of injury. Which is what all these patients had. And his liver test normalized. And it's been one and a half years after his injury. In 2022, which is the last records that we have, his liver tests were normal.
Great, and what's his prognosis?
His noxious agent, his hydrazine was removed, so he hasn't had any trouble with any elevation of tests since. His prognosis should be good.
Okay. And what does that mean for the potential for acute liver failure in the future?
As long as he doesn't get re-exposed to hydrazine, then he should not sustain an episode of acute liver failure.
And our next individual that you reviewed was Carrie Mano on slide 30.
Mr. Mano, in 2020, November, presented to St. Rose Dominican Hospital, St. Barney campus, with GI symptoms for 3 days, high bilirubin, high serum transaminases, and then he was discharged and returned back on the 15th, for which he was there for about 3 days. Yeah. Slurred speech, neurologic symptoms, clotting disorder, high ammonia levels, and an ultrasound showed a hyperechoic liver, and some fat is, likely fat is sparing. That doesn't mean that there's fat, it's actually not fat, but he was, the ultrasound showed a hyperechoic liver. Bilirubin was 6, transaminases were high at that point.
And what about in 2021?
In 2021, he had the last visit with Dr. Karan, his GI doctor. In January 15th, he had unremarkable blood work with respect to the liver.
And based upon what you reviewed, if we go to the next slide, can you tell us about any conclusions that you reached as it relates to Mr. Mana?
Mr. Mana was diagnosed with acute liver failure, and this was a hepatocellular type of injury. And his prognosis is good. His liver test normalized shortly after November of 2020.
Did you reach any conclusions as a result of that?
Yeah, I mean, the conclusion is that I don't think he should sustain another episode as long as he's not exposed to hydrazine again.
And moving on to our last plaintiff that you took a look at, Ms. Nally. What was her medical condition in 2020?
Mrs. Nally in 2020 was a 72-year-old female presented to St. Rose Dominican Siena campus with disorientation, nausea, vomiting, high serum transaminases, a little bit of clotting test, and she had a CAT scan and an ultrasound that both showed fatty liver changes. She was discharged on the 18th of November.
And what happened with Ms. Nally's treatment in 2021 and 2022?
In 2021, in June, her liver function tests were normal. In April of 2022, her transaminases and bilirubin were also normal.
And based on what you reviewed, did you reach any conclusions as it relates to Ms. Nally? And we can go ahead and go to slide 33.
Mrs. Nally had a significant hepatocellular type of injury in November of 2020 with neurologic and GI symptoms. Fatty liver was noted upon presentation. Her liver test normalized in June of 2021 and remained normal as of April of 2022.
Were there any ongoing signs of inflammation?
She did not have elevation in her liver test back then in 2022, so that would indicate none at that point.
Okay. And what's your opinion about her future prognosis?
As long as she's not re-exposed to hydrazine, which we don't expect, her prognosis should be good.
Okay. What I'd like to do is go back to slide 4, if we could. And so for the first two plaintiffs that you looked at, Ms. King and Ms. Wardney, it's your opinion that these two individuals will need ongoing treatment as it relates to their autoimmune process, correct?
Yes.
Okay. As it relates to the other 6 plaintiffs that you took a look at, do you believe that they have any ongoing issues into the future?
Ongoing issues that they have? Can you repeat that question?
Yes. Do you believe that they have any ongoing medical issues as it relates to their prior hydrazine exposure?
Well, they could have ongoing medical issues that I'm not aware of. My opinion is that they didn't have any ongoing liver issues up to the point that we have follow-up on them.
Understood. And have all of your opinions been stated to a reasonable degree of medical probability?
Yes.
Thank you, Doctor. I'll go ahead and pass you.
Is it still morning? Good morning, Dr. House.
Good morning, Mr.
We just had the pleasure of meeting today before your testimony started, is that right?
Yes.
So again, my name is Robert Eglett, and I represent Lisa King in this lawsuit against Real Water. Again, it's nice to meet you. I'm going to try to be brief. I've read your prior deposition testimony, I've looked at your reports, and I'm just going to focus on my client, Lisa King, today, okay?
Yes.
Okay. Now, you know Lisa King's physician, one of her treating physicians, Dr. Gish.
I know him, professionally and at meetings and things like that. I met him a few times. Yeah.
And you would agree that he's a very competent and recognized nationally as well as in Asia as a highly respected physician, correct?
Highly respected, yes.
And you would agree that he is very well respected in the field of treating various liver-related diseases and injuries, correct?
Yes.
Okay. You have no criticism of any of his treatment he provided to Lisa, correct?
Not at all.
Okay. And so you would defer to Dr. Gish regarding the treatment options for Lisa, given that he actually saw her in a clinical setting and was her doctor versus you just doing a review of Lisa's medical records, right?
Right.
Okay. And in fact, as far as the physicians that have treated and continue to treat Lisa King in your area of expertise, you have no criticism of her treating physicians, right?
Correct.
Okay. And so you would agree that Lisa King is seeing highly respected doctors to deal with her autoimmune hepatitis and her myasthenia gravis, right?
Yes, I mean, I don't know the myasthenia gravis doctors, but she's getting treated. That's what I can say.
And that would apply to all of the many physicians who have treated Lisa for her liver-related injuries or disease, including Dr. Rakela at the Mayo Clinic and including Dr. Mahajan, Lisa's neurologist, right?
Yeah, I have no criticism.
Okay. You're aware that Dr. Hudson is a hepatology, gastroenterology, and liver transplant expert, correct?
Yes.
Okay. You are aware that Dr. Hudson is a professor of medical and medicine at the University of Utah School of Medicine and a member of the University of Utah's Medical Center Liver Transplant Program, right?
I'm aware, yes.
You're aware that Dr. Hudson has been the chief of the section of gastroenterology and hepatology, the director of hepatology, and the director of digestive diseases programs at West Virginia University Medical Center and Ruby Memorial Hospital in West Virginia, correct?
Yes.
Okay. And you're aware that Dr. Hudson was the director of hepatology and medical director of liver transplantation at the University of Maryland Medical Center, as well as a professor of medicine at the University of Maryland School of Medicine, right?
Yes.
And you're aware that Dr. Hudson, while he was the director of hepatology and director of liver transplantation at the University of Utah, he actually started the liver transplant program there, correct?
Yeah, I read something about that in the transcripts, and I'm aware of that, yes.
So you were aware that Dr. Hudson was formerly a member of the renowned liver transplant program at the University of Pittsburgh Medical Center, right?
Yes.
Okay. So you would agree that Dr. Hudson is unequivocally qualified to provide expert opinions regarding Lisa King's autoimmune hepatitis and her future treatment needs, along with medical providers at Loma Linda who are treating her, correct?
Yes, I agree.
And so you would agree that Lisa King has seen some highly respected doctors to deal with her autoimmune hepatitis, right?
Yes.
You're aware that Dr. Mahajan is Lisa King's neurologist who diagnosed her with myasthenia gravis, right?
I'm aware of that.
And you are aware that Dr. Mahajan has been continuously treating Lisa for her myasthenia gravis since 2019, right?
Yes.
Okay. And you are aware that Dr. Mahajan has testified that myasthenia gravis cannot be cured, and that only the symptoms can only be treated, correct?
I don't know what he testified. I mean,
Well, you have no disagreement with that if that's what he testified to, correct?
I would not disagree with anything about myasthenia.
Okay. And so are you aware that Dr. Mahajan has testified that myasthenia gravis is a progressive disease and therefore Lisa's symptoms from myasthenia gravis will only get worse as time goes on? Are you aware of that?
I have no opinions about how this disease is going to go.
You certainly don't disagree with that, right?
No, whatever he says, I defer that to him.
So you would agree that for someone with myasthenia gravis, knowing that their symptoms will only get worse as time goes by, that in your professional experience with any disease where it's going to get worse, those people are likely to suffer from anxiety, mental distress, and perhaps even post-traumatic stress disorder, right?
Yeah, I would not disagree with what Dr. Mahajan has testified.
All right. And you're aware that Lisa's treating neurologist, Dr. Mahajan, has concluded that Lisa requires IVIG treatment, correct?
Yes.
Okay. And you're not offering an opinion that IVI treatment will not be required, correct?
Correct.
Okay. And in fact, you believe whether Lisa King needs IVIG treatments in the future, how frequently she will need IVI treatments, or how long she will need IVI treatments for should be determined by her neurologist, Dr. Mahajan, right?
Yes.
Okay. So you would defer to Dr. Mahajan's opinions on how often and how long Lisa will require IVI treatments, correct?
Correct.
Okay, so you were made aware that in 2003, Dr. Mahajan put Lisa King on a schedule of receiving 2 rounds of IVIG treatments at his office every month, right?
I'm aware of all those records. I reviewed everything, yes.
And are you aware he did this to try to better control her symptoms? Because when she was just getting the IVIG treatments, when she had a myasthenia gravis flare-up or exacerbation, that the flare-ups would be so bad that her throat would close up to the point that she had difficulty breathing. You were aware of that?
I am aware of the symptomatology that led them to do the treatments, and they had some agreement between the two of them about how often they would be done. That's what I remember.
Right. And are you aware that she had 2 IVIG rounds at each treatment at Dr. Mahajan's medical offices in February, March, and April 2023?
I would not disagree with that. I mean, I don't have that in front of me, but I know she went through a multitude of treatments.
Have you been informed that Lisa King had a severe, and I think you do know about this because you talked about it in direct, so you have been informed that Lisa King had a severe myasthenia gravis exacerbation in mid-February of this year and had to be checked into the hospital on an emergent basis on Valentine's Day and stayed through the weekend to receive 3 rounds of IVIG treatment.
Yes, I was just given those records and I reviewed them, and that's correct.
And are you aware that Dr. Mahajan testified that Lisa's throat was closing up and it became difficult for her to breathe prior to that, those IVIG treatments?
I don't know what he testified, but I mean, I did review the records certainly.
Are you aware that the hospital stay and the 3 rounds of IVIG treatment cost over $200,000?
I don't disagree with that.
Are you aware that shortly after that, Dr. Mahajan is now insisting that Lisa have 2 rounds of monthly IVIG treatments at his medical office every month to try to prevent these myasthenia gravis exacerbations or flare-ups that send her to the hospital on an emergent basis and to better control her symptoms?
I think whatever Dr. Mahajan says should be done.
Okay, are you aware that Lisa's life expectancy per the U.S. government tables, based upon her current age of 52 and her gender and race, is another 34.3 years?
I wasn't aware of her life expectancy.
You have any reason to disagree with that?
No, I don't.
Okay. Are you aware that Dr. Mahajan has recommended and ordered that Lisa have 2 rounds of IVIG treatments monthly for the remainder of her life?
I don't disagree with that.
Okay. Are you aware, Dr. Alsina, that each IVIG preparation for 1 round of IVIG treatment is made from the pooled plasma of an average of 8,000 blood donors?
That sounds correct.
Okay. And are you aware that since it's derived from donor blood, IVIG carries the potential risk of transmitting infectious and blood-borne diseases?
That's a potential risk. They're tested, but there's always a potential risk of transmission.
And so yeah, I understand you're aware that they're tested, and while their screening techniques are used, it is impossible to completely eliminate all possible infections from IVIG preparation, correct?
Correct.
Okay. And are you aware that although IVIG is extracted from the plasma obtained from donors screened for infections, there is still a potential transmission of infectious diseases such as HIV, hepatitis B, and a neurodegenerative condition caused by faulty proteins that leads to mental deterioration, involuntary muscle movement, and other central nervous system deficits that's referred to by the initials CJD because it's virtually impossible to pronounce. Are you aware of that?
I know what that disease is, but I agree with the potential risk of transmission with any sort of blood product.
Are you aware that there's also is also always a risk that the product contains an infection that has not yet been recognized, either because it's a previously unknown disease like COVID was, or because the donor's infection was in such an early stage that their blood gave no clues?
It's possible, yes.
So you're aware that are you aware that Lisa has had a total to date of 21 rounds of IVIG treatment since 2019, with an average of 8,000 donors per round?
I don't disagree with that.
You'd agree that 21 times 8,000 is 168,000 donor antibodies that have entered her blood, right?
Yes, if you say so, that's the correct amount, yes.
And you would agree that since Dr. Mahajan has testified that she will require 2 rounds of IVIG treatment per month for the remainder of her life, and if we assume Lisa lives to her statistical life expectancy, she has 24 rounds of IVI treatment per year, as Dr. Mahajan has recommended, that we can calculate the approximate number of different donor antibodies that will enter her blood.
It can be calculated, I'm sure.
And 24 rounds of IVIG treatments per year times 34 years times 8,000 donors on average. Would you disagree that's 6,528,000 different donors,
No,
right?
I don't disagree.
Okay. And if we add the 168,000 donors she's already had, that is a total of just under 7 million different donors' blood entering her blood during her lifetime, right?
If that's the calculation, and that's what it is, Mr. But,
Pretty scary, right?
well, yeah, when you undergo multiple transfusions, you can acquire any disease as possible.
Would you agree that knowing that the number of blood donors for plasma for the IVIG treatment could cause her to suffer from severe anxiety, emotional distress? Would you agree with that?
Yeah, I mean, I think that would be hard to sustain.
And even post-traumatic stress disorder, right?
It's possible, yes.
And you would agree that since Lisa's major symptoms when she is having an myasthenia gravis flare-up or exacerbation is her throat closing, when she has been told multiple times that if her throat closes up and she can't breathe and she's too far from a hospital, that she'll likely die, that could cause her to suffer from severe emotional distress, anxiety, and even maybe PTSD?
That would be anxiety causing, I would think. I just don't know the circumstances of what she's going through. I don't have that knowledge.
Would you agree that since myasthenia gravis is not curable and Lisa will suffer from this disease for life, that her symptoms will only get worse and she will continue to have 2 rounds of IVIG treatment every month for the remainder of her life, with an average of 8,000 donors required for each round of IVIG treatment 24 times per year for the next 34 years, that more likely than not, she will suffer from severe emotional distress, anxiety, and PTSD for the remainder of her life, right?
I mean, she may be suffering now, I just don't know enough about her psychiatric anxiety conditions, Mr. Edward. I
Are
mean,
you aware that Lisa has been diagnosed with post-traumatic stress disorder as a result of her liver injury and the 2 autoimmune diseases she has now from drinking hydrazine contained within the water?
yes,
Are you now aware that in fact, Real Water has stipulated that Lisa has been diagnosed with and currently suffers from post-traumatic stress disorder?
yes,
Okay. And you don't have any reason to disagree with that, right?
I know.
Okay. And you would agree that that psychological and or neuropsychological treatment is appropriate for patients suffering from post-traumatic stress disorder, right?
Okay,
I'm asking you as a physician who's done psych rotations as part of your training and education, you would agree that that not psychological and psychological treatment and neuropsychological testing is appropriate for patients who have been diagnosed with post-traumatic stress disorder, right?
I would agree with that.
Okay. And you would agree that Lisa King should be able to seek psychological counseling and neuropsychological testing for her diagnosed post-traumatic stress disorder if she wishes, correct?
Sure.
December 2018 report, do you have that in front of you?
I have it on Mrs. King.
On this, yeah, we're just talking about Lisa.
Yep.
Okay.
I have it right here.
All right, so on April 24th, 2019, her liver enzyme levels were high, correct?
They were high, the serum transaminases were high.
On May 31st, 2019, they were high, correct?
Yes,
In June 2019, they were high, correct?
yes,
In July 2019, they were high, correct?
yes,
Okay. In September 2019, they were high, correct?
yes,
In July 2020, they were high, correct?
Yes,
In August 2020, they were high, correct?
yes,
And in May 2021, they were high, correct?
yes.
Okay? And it wasn't until the end of 2021 that her liver enzyme tests came down, were starting to be consistently normal, correct?
I see that there in that chart, that's correct.
Okay. All right, and finally, Dr. Alsina, because of Lisa's King's autoimmune hepatitis, you cannot rule out that Lisa may have a relapse in the future, correct?
I can't, I cannot.
Isn't it true that you cannot rule out in the future that Lisa could possibly have require a liver transplant, correct?
I cannot rule it out.
Now, you're aware that Dr. Hudson testified under oath that it is the median survival after a liver transplant is 12 to 13 years.
There's different data, depends where you get the data from. I've looked at this many times, Mr. Gregory, I've done a lot of cases about
You
this.
think Dr. Hudson hasn't looked at this many times?
No, I didn't say that.
Okay.
But I'm up to speed with it.
Okay, do you think Dr. Hudson's up to speed to it as well?
I think he's up to speed too, but I think it's, 12 to 15 years and,
So we can agree on 12 to 15, right?
yeah,
Okay. Hypothetically, if Lisa were to relapse in the future and require a liver transplant, from a fairness standpoint, do you think Lisa should have to bear the risks of that mental worry and burden and likely exacerbation of her post-traumatic stress disorder and the sorrow of a shortened life and all that brings with it?
I don't think it should be her.
You don't think it should be her, right?
Correct.
Let's see if we can start with some easy questions, Dr. Alsina. Both you and Dr. Hudson are board certified hepatologists, is that correct?
He's a hepatologist, I'm a board certified surgeon, general surgeon.
Okay. And you do liver transplants, correct?
Yeah, I've done that my whole career, yes sir.
Okay. And you know that Dr. Hudson has been the head of liver transplant departments, correct?
I am aware of that.
And as Mr. Anglin discussed with you, he's been the head of several hepatology departments as well as gastroenterology departments, correct?
He has been.
All right. Is it your understanding that the defendant's expert, Dr. Robin, is neither a board-certified hepatologist nor board-certified gastroenterologist?
I'm aware of that, yes.
Is it fair to say that he is a pathologist?
He's a pathologist.
Is it also fair to say that pathologists typically do not treat patients directly for hepatology or gastroenterology issues?
They do not.
That would be reserved for hepatologists and gastroenterologists, correct?
Yes, clinicians.
That's right. And he's neither, correct?
He's a pathologist.
Not a clinician, not a hepatologist, not a gastroenterologist, correct?
Correct.
And in fact, in terms of treating patients with hepatology issues, that would be the hepatologist, both leading up to a diagnosis as well as a prognosis, correct?
Yes.
And as well as following treatment after a diagnosis has been made, correct?
Correct.
Be it through a liver transplant or just continuing care, correct?
Yes, that's not a purview of pathology.
Thank you. And so Dr. Robin would not be the person treating patients for hepatology issues or gastroenterology issues, be it before prognosis or even after before diagnosis as well as after diagnosis, correct?
I agree with that.
All right. And in terms of future care, that's also reserved to clinicians, be it hepatology or gastroenterology, correct?
Yeah, or the other liver specialists or whatever specialty that involve transplantation or chronic diseases or whatever.
Right. But none of those would be the pathologist, correct?
Correct.
In terms of literature, Dr. Alcina, and I'm talking about literature related to hydrazine and its effects on the human liver, are there many peer-reviewed articles out there?
There's a couple that we have reviewed thoroughly, your side, my side, and we know what the literature shows.
Is it fair to say that you simply cannot compare all DILI to hydrazine and its effect on the human liver?
Right, because DILI is a term used for drugs and hydrazine is a different toxin, and we didn't know much about hydrazine until this series of cases.
That's right. And how many people that are you aware of that have suffered hydrazine poisoning as a result of drinking real water?
Roughly, I'm aware of, based on reading a lot of testimonies and depositions and things that have been provided to me, probably over 50.
And is it fair to say that all of them suffered some form of acute liver failure or acute liver injury?
Yes.
And you would say that that's even more pronounced than any other than, of course, Tylenol, or alcohol. That level of injury related to one drug, is that unusual in your span of 30 plus years of medicine?
Some of these were severe cases, some of them were milder, but I've seen many severe cases in my career too. So, I've seen some bad ones too, from that required transplants, and I've seen some people that recovered. And it's not like the hydrazine ones were the worst that I've seen, because I've really seen some other bad cases in my career.
Sure, but you're aware of at least 2 people, young males, that have suffered liver transplants because of hydrazine, correct?
I'm aware of those. I was involved with those.
And you're aware of 2 deaths because of hydrazine, correct?
Yeah, from peripheral cases that I wasn't involved, but some people have died.
Yes, based upon the MMWR report, there was a older female who died as a result of consuming real water that had hydrazine in it, correct?
Yes.
And also, you're aware of the 1971 article where a machinist died after being exposed to hydrazine, correct?
Yes, I'm aware of that literature and the naval literature and all that. Yes, sir.
And so based upon the 50 or so patients that you've reviewed their medical records of, as well as the peer-reviewed literature, hydrazine can cause deaths, it could cause liver transplants, and of course, it could cause acute liver injuries and failures, correct?
It has caused all those, yes.
And it can cause autoimmune hepatitis, correct?
We have seen that in 2 cases here, at least here.
Yes, the 2 that we're speaking of today, Ms. Bourdonnais and Ms. King, correct?
Yes.
And in terms of all the questions that Mr. Eglett asked of you related to autoimmune and what Ms. King is likely to suffer from, would you agree that the same would be true for Ms. Bourdonnais?
Yes, Mrs. Bourdonnais is not on the treatment now, but they both had that autoimmune post-hydrazine condition.
And I asked that question just for efficiency purposes, so I don't have to ask all the same questions that Mr. Eglett asked.
Yes.
Now, we both understand that Ms. Bourdonnais does not have myasthenia gravis, but she does have autoimmune hepatitis caused by real water, correct?
Yeah, she had it back then and she's in remission. She's not on treatments right now.
Okay, and we'll get to that.
Yes.
All right. Another area I think would be that you can agree to is the cost of monitoring and the requirement of monitoring. I believe you've testified to that in the past, correct?
Yes.
And you agree with Dr. Hudson that the average cost is somewhere between $1,000 and $1,500 for elastographies twice a year. Is that correct?
I agree with that.
All right. And you agree that it would be reasonable for each of these plaintiffs to undergo testing twice a year for the next 20 years, correct?
Yeah, whatever Dr. Hudson recommended, I don't have any objections.
All right. And in terms of those with autoimmune hepatitis, you also agree that every 3 to 4 months they should be tested, correct?
Yeah, they should be tested biochemically with blood work, yes.
Okay. And you also agree that those tests are roughly 1,000 to, I'm sorry, $1,200 to $1,600 a year, correct?
It could be. Sounds ballpark accurate.
Thank you. You mentioned in an article earlier today during your direct examination by Mr. Watson, a 2018 article. You recall that article?
It went from actually the chronic Dilly article.
Yes. Is it fair to say that that article came out before anyone knew of hydrazine being in real water?
Yes, it did.
Would you agree that that article did not include the effects of hydrazine on the human liver?
Not at all.
All right. So when you were giving the percentages, is it fair to say that those percentages are relegated to DILI and the known causes of DILI as of 2018?
You're right. Based on the experience of the Dilly network and the patients they had in the database, that's where the information came from.
That's right. Which means it did not include the likelihood of continuing care for those who suffered from DILI caused by hydrazine specifically, correct?
It doesn't have the natural history of the hydrazine cases.
So my statement was correct. Is that true, sir?
Yes.
All right, perfect. And in fact, if you were to look at that article, I believe the article actually indicated that an acute injury from a drug may lead to residual fibrosis, portal hypertension, and worsening of a background liver disease. The biochemistries may fall, but the patient may be clearly worse off than before. Such cases are difficult to label as resolved, even though the pathophysiology of the acute injury itself may be gone. Do you agree with that?
Yeah, some drugs, I agree with that. Some drugs can cause problems like that are notorious. They have that signature, and if you don't withdraw them, they can lead to kind of chronic problems.
Is it fair to say, doctor, that all of the patients in this that in this case all suffered some form of acute liver failure or acute liver injury caused by hydrazine in real water? I'm only talking the ones he's reviewed, and that's fine. We can have that understanding. Is that fair enough?
I agree with your statement.
And it's also fair to say, doctor, that hydrazine injures the human liver, which could include fibrosis, cirrhosis, cirrhotic nodules, steatosis or fatty liver, necrosis, liver transplants, and even death.
We have seen all those things in cases of hydrazine.
And is it also fair to say, based upon the Loma Linda article and the 2018 F16 article that you're aware of, that the exposure could be less than a minute and cause injury?
Yeah, I mean, some of those patients were inhalation injuries and they were sick immediately.
And in the Loma Linda, there was one of the patients that had a fibrosis had consumed real water for less than 2 weeks, or I believe 2 weeks. If you like, I can show you the article.
Yeah, I mean, you can show it to me. I mean, I don't disagree. I mean,
show this to you. This is Exhibit 10, Dr. Hudson. Okay, patient number 1 in terms of duration of exposure, please.
yes. And can I see the front page of the
Oh, of course you can.
Two weeks earlier, I mean, patient number 1,
Yes.
that's what it says.
And in looking at the results of patient number 1, isn't it true that that person's histology indicated that there was paracellular fibrosis, as well as portal tract inflammation, just from 2 weeks of exposure, correct?
That's what it says. That's a patient that is not in our series of patients, so I just want to disclose that.
Right. But you're aware of that based on your review of the literature, correct?
Yes.
All right. And you're aware that the plaintiffs in this case consumed real water for longer than 2 weeks.
I think so. I think they did, yes.
Is it fair to say that hydrazine exposure can cause permanent liver injuries?
It's fair to say in some patients, I mean, if we don't have precise histologic follow-up on these people, we may not know, but that's fair to say.
And it is also fair to say that you cannot rule out that each one of these patients has suffered some form of permanent injury.
I mean, histologically at the microscopic level, it's one thing because everybody's focused on permanent, but we're only looking at microscopy, so how are they doing clinically is different from what's in a biopsy.
And so, and I appreciate that response. But isn't that your response is another way of saying, at this point in time, in front of this jury, you can't rule out that each one of these plaintiffs have suffered some form of permanent injury, correct?
Right.
Isn't that correct?
Correct, unless we do a biopsy on these people, we would not know what's going on there to this date.
And you know for sure that Ms. Bourdonnais and Ms. King have suffered permanent injuries because they have now autoimmune hepatitis, which will be with them forever, correct?
Well, they have that condition. I mean, what we know, Mr. Parker, is that from the drug-induced liver injury literature that the autoimmune cases tend to resolve, and they don't seem to require long treatments, and they don't seem to relapse. But you know, this is a different toxin. So well, I forgot your question now.
Well, see, that's one thing that Mr. Anglett was trying to warm you up for me. I try to ask you questions that will lend itself to yes or no.
Yes, yes.
And typically, if you say yes or no, you remember the question.
Yes.
So let me try again, okay? Is it fair to say that both Ms. Bourdonnais and Ms. King have suffered permanent illnesses now caused by their consumption of real water with hydrazine?
Yes, I mean, they have that autoimmune label.
So Dr. Alcina, those are permanent conditions, correct?
Yes.
Is it fair to say, based upon the literature you've read, that there's no cure identified in the literature for autoimmune hepatitis, correct?
I mean, the literature doesn't address cure.
So is it fair to say that you don't know whether or not it can be cured?
I don't know about the DILI. I think the idiopathic autoimmunes you cannot cure.
Thank you. And is it fair to say that the Andre article, the September 2023 article, the nomenclature, diagnosis, management of drug-induced autoimmune-like hepatitis, you've read that article, correct?
I read it thoroughly, sir, yes.
And is it fair to say that within that article, it indicates that there's a likelihood beyond 4 years of relapse?
There's a citation there. See, the article is about what they obtained from their consensus conference, and then they quote the Latin America and the Spanish registry in a reference there where the relapse rates can be up to 50% at 4 years. That's quoted in their article. They just make that statement based on an outside data that they brought into the article, but they have the opinions that it was kind of rarely going to relapse, according to Andre and the authors that wrote that paper.
Well, the authors that wrote this paper indicate that as time goes on, there's a more likely chance of relapse, correct?
Yeah, they're quoting a separate registry of patients, and they just wanted to include that in their paper.
Dr. Alcina, the second article is the clinical presentation, causative drugs and outcome of patients with autoimmune features in 2 prospective DILI registries. We informed you of this article, correct?
Okay, what's the author's name?
The lead author is Garcia-Cortez.
Yeah, that's the one.
Okay, you're familiar with this?
I'm familiar, that's the one that they quote that rate at 4 years.
Right, and these articles weren't quoted in your report, but they were shown you during your deposition, correct?
Yes, they were shown, I had a chance to review them more thoroughly since, yes.
Okay, and based upon these articles, you would agree that as time goes on, there is a greater likelihood that both Ms. Bourdonnais and Ms. King will suffer relapse of autoimmune hepatitis, correct?
Yeah, according to that reference, yes, at that particular time period, there's up to 50% according to those two registries that are quoted there.
I'm going to show you again Exhibit 119. This is the article we were speaking of for September 2023. It says discontinuation of immune suppression was successful in all DI-ALH cases, whereas 65% with AIH had a relapse after withdrawal. Are you aware of that?
65% of the idiopathic autoimmune cases. Is that, I mean, I can read it, but then they may be talking about idiopathic autoimmune, Mr. Parker.
Okay, did you review that in the article?
I don't know that I have reviewed that article from Garcia.
This is the article from Andre.
Okay, I reviewed Andre's article. Yes, I have it right here.
Let me just ask, did you recall reading the 65% in the Andre article? That's a yes or no question.
I have to look, I can't remember, I have to look for it.
Okay, you don't recall whether or not you saw that?
Correct.
Okay. You don't disagree that it's in the article, is that correct?
No, we just have to agree on what type of autoimmune hepatitis they're talking about, whether it's one or the other, because they behave differently.
Mr. Anglin asked you whether or not you could rule out liver transplant for Ms. King. Do you recall that question?
Yes.
Would it be fair to say that you can't rule out whether or not any of these patients that you review the medical records will need some form of medical care related to their livers in the future, in addition to monitoring, of course?
So I agree that they're going to need medical care monitoring for their livers. I think they should.
The rest of their lives?
Sure. I mean, yes. I mean, and most of us will have that sort of monitoring as well. So it should be done at whatever time period is appropriate, whether it's twice a year or once a year.
And you can't rule out a liver transplant. You can't rule out further acute liver injuries. Those things you can't rule out, correct?
I cannot rule it out.
Well, let's just ask it again and get a clear answer on the record. Dr. Alcina, is it true that you cannot rule out that all of the patients for records you've reviewed may require future medical care related to further acute liver injuries, leading up perhaps even to a transplant, correct?
I cannot rule out that they're going to have an episode like that or a transplant. I mean,
thank you, sir.
Yeah.
Is it also fair to say that because hydrazine has such a toxic effect on the liver that there's been no human tests for hydrazine in the past? Is that fair?
No, I mean, other than that, those naval articles, there hasn't been any human studies on hydrazine, or, systematically, or I don't think that has been done.
It would be unethical to do so, correct?
Right.
It would be against your oath as a physician, correct?
I would agree, yeah.
And as a result, tests are done on animals, correct?
That's what we found out. So there was some animal literature on hydrazine, yes.
I believe there are dogs, cats, no, sorry, cats. I think dogs, rats, mice, I think hamsters. Do you recall?
I recall some of the animal experiments. I didn't go into them too closely, but I went over the human articles.
And based upon those articles, isn't it fair to say that hydrazine causes deaths, fatty liver, necrosis, fibrosis?
I think we know that from the humans. Yeah, the answer is yes. In humans, we know that.
It happened with the pets. It happened with the animals, and it also happened with humans, correct?
Yes.
Did you find in your review of the medical records that the majority of the plaintiffs in this case suffered some form of fatty liver?
Many of the patients in this series, not everybody had fatty livers, but can you ask me the question about, was it the literature or the patients that I've been exposed to?
No, we started with the literature first.
Yes.
Based upon animal testing. seeing a similarity in terms of from the histology, fatty liver, necrosis, fibrosis, all discovered all the way up to death for these animals, correct?
Yes.
And we found similar findings based upon the literature and the medical records you've actually reviewed, correct?
Yes. You asked me something about fatty liver specifically.
Yes. In terms of the plaintiffs in this case, the 8 that you reviewed, did you find fatty liver in several of those?
Yeah, we already went through them. I mean, we can count them. A couple of them had severe fatty livers. That's unquestionable.
So in addition to the 8 plaintiffs in this case, you said you're somewhere around 50 in total that you reviewed up to now, correct?
I haven't reviewed all the cases because I didn't review the pediatric ones, but I reviewed a few dozen cases.
And you're aware of the fact that in the FDA report, there were 21 probable cases related to the consumption of real water with hydrazine, correct?
In the FDA report,
You're familiar that the FDA, the Southern Nevada Health District, and the CDC did an investigation, correct?
yes, I am.
And you're aware of the fact that the MMWR spoke about that, correct?
Yes.
And as a part of that investigation, they discovered at least 21 probable cases between Nevada and California, and I believe Arizona, correct?
Yes.
All right, so we know that with all of those cases, based upon the literature, they all suffered similar acute liver injuries, correct?
Yes.
Hold on one second. I need to look at your report. I'm sorry, your slides. Have it here a second ago, Salter. Here it is. You have it in front of you? I believe you start with Ms. King, so I will start with Ms. King. Did Ms. King suffer, from your review of her medical records, did Ms. King suffer from fatty liver based upon her histology?
No, Mrs. King did not have fatty liver on her biopsy. She had autoimmune hepatitis.
Okay. And you're sure of this? Is that what you're saying?
I'm looking at the report here.
Sure, please. Is steatosis another way of saying fatty liver?
Yes, I don't see it here in the report from, it's the same, steatosis and fatty liver is the same thing.
I would have you take a look at her report dated August 4th, 2020. That says severe steatosis. In fact, it says steatosis 0.81, H as in high.
Okay, and can you point me where you read that?
Sure, I'll actually show it to you. Exhibit 1041, page 31.
Okay, this is the NASH fibrosure test, which is reading her inflammatory activity as NASH, but she already had a biopsy, Mr. Parker. Okay, so this test is reading the inflammatory activity from the autoimmune hepatitis as fatty liver.
because it's a test that's used for inflammation. Dr. Gish made that clarification, and that's in my slides. So you have to go by the biopsy. The biopsy is the ultimate test on her. So you're saying the FibroSure saying that she has a fatty liver is incorrect? It's incorrect because it's a test that was made for NASH, and she doesn't have NASH. The inflammatory activity from the autoimmune hepatitis is what that test measured. Dr. Gish clarified that in the progress notes. I have them there in my, on page 8, October 6th, Dr. Gish agreed that the FibroSure was a false positive for NASH, FibroSure indicating fatty liver. Okay, so FibroSure was a false positive for NASH, FibroSure indicating fatty liver, but no changes of fatty liver noted, but no changes noted on liver biopsy and no evidence of other metabolic syndrome. She doesn't have fatty liver on the biopsy, Mr. Parker. That's established. Okay, so would you believe, so if Dr. Robin was to say that the FibroSure test is more reliable than biopsy, he would be wrong? I don't know if he said that, but the biopsy is the gold standard for pathology, not non-invasive testing, whether it's ultrasound or FibroSure. I think we would be in agreement that a biopsy is the gold standard. Okay. Did Ms. King have fibrosis? Okay. Mrs. King had stage 1 fibrosis on her liver biopsy, according to the hospital record reports. Was there a time when the fibrosis actually increased, found to have increased in her liver? Well, she only had 1 biopsy. Okay, so if we were to look at Exhibit 1042, page 18, it says a mild increase in fibrosis. Have you seen that? Okay, you're not showing me the previous page. This is a progress note from Dr. Gish. Sure, more than happy. Okay. So there is active disease and mild increase in fibrosis. So what he's saying there that she has fibrosis. He doesn't say that her fibrosis has increased. She has abnormal fibrosis in that test. That's what Dr. Gish is stating, Mr. Parker. So when you indicated on your slide that there's no fibrosis and no liver fat, you would agree that that's incorrect? The liver fat is, I'm going by the biopsy and by Dr. Gish wrote in his record. I think we're in agreement she does not have histologic changes of fatty liver. Well, I'm not saying we agree, but I understand what you're saying. You're saying that the FibroSure result is not, you're not relying upon that to show fatty liver. But in terms of fibrosis, we see it here in the laboratory results, correct? Yes, I mean, I'm relying on the biopsy, Mr. Parker. Okay. Now let's go to the board name. Yes. You indicate that Ms. Bourdnave has fatty liver, correct? As of October 24th in 2019. Slide number 17, if you want. Okay, so page 17 doesn't say much about a biopsy. Look at the last bullet point in 2019. It says October 24th. You see that? Yeah, there's an ultrasound elastography. Yes, and then in the parentheses at the bottom it says 10 to 33% hepatic steatosis. Okay, that's in that non-invasive test. That's what it says there. Yes. So she had fatty liver, correct? According to that test, she had fatty liver. The original biopsy doesn't mention much of that, but according to that test, it shows that. All right. Does it also show in the microscopic impressions for her pathology report that she had hepatocyte necrosis? Yes, sir. Which is dead liver cells, correct? Yes. And from our research, or from your research, on the effects of hydrazine on the human liver, it can cause or kill liver cells, correct?
Yes, anytime any of these patients sustain liver injuries, they're gonna kill liver cells. So it's not uncommon.
And so each of these plaintiffs in this case, and of course, they all consumed real water, they all suffered acute liver injuries, they would have suffered the death of liver cells because of their consumption of real water, correct?
They all did, they all had high transaminases. That's what the hepatocytes are doing. They're dying and they're regenerating, yes, sir.
Okay. And in terms of the death of those cells, they can be quantified in a biopsy, correct?
The biopsy doesn't look for that. The biopsy looks at patterns. They don't count how many, just like fat. No, I mean, they count fat percentages, but they don't count necrosis percentages.
But it shows on the biopsy.
It shows on the biopsies.
And without having a later biopsy, you cannot say definitively that the dead cells have regenerated, correct?
I cannot say that.
But what we do know, and what you can say to a reasonable degree of medical probability and or certainty, is that consuming hydrazine-laced real water resulted in the death of liver cells for all of these patients, correct?
Yes, it did.
And no expert, without the benefit of having a later biopsy, can tell you that those dead cells have regenerated, correct?
No, I mean, you cannot say what's happening now without a biopsy.
And as a result, no expert can say that those were not permanent injuries in terms of the death of those liver cells from consuming real water with hydrazine, correct?
Correct.
Is it also fair to say that Ms. Bornave has been diagnosed with hepatomegaly?
Yes.
And so I think your next plaintiff is Ms. Land Van Buren?
Yes, sir.
Correct?
Yes.
So in looking at Ms. Land Van Buren's medical records, did you notice how high her lactic acid was?
Yes, it was high. She had lactic acidosis.
Is that an indication of liver damage?
It can be. Patients in acute liver failure can go into lactic acidosis.
And what happens, what's that an indication of in terms of the liver itself?
I mean, that's a severe injury. I mean, people with mild drug injuries are not going to elevate their lactic acids, but severe ones, acute liver failure patients can.
Could that result in also, when we talk about liver injury, some form of hepatocyte necrosis?
Yeah, these things are occurring together. The acidosis is a byproduct of the body, and the liver doesn't clear it, and then it accumulates.
So when you have a lactic acid at 4.56, that's an indication of severe liver injury?
Yes, I mean, we already know she had a severe liver injury.
All right.
But in addition, she had the acidosis.
And when you see an INR of 11.39, is that also consistent with severe liver injury?
Yes, sir.
All right. And again, unless you have a later biopsy, you don't know how severe the injury is or whether or not the injury has repaired itself, correct?
Right. This lady did not have a biopsy, but you're correct.
All right. And knowing that she did not have a biopsy, is it fair to say that you cannot rule out that her liver injuries were permanent?
I can't rule it out. I don't know exactly what's happening with that liver macroscopically now.
Okay. Have you ever seen a patient with an INR that high?
Are we letting?
11.39.
I have. I mean, I've seen acute liver failure patient with INRs in that range.
How about lactic acid at 4.56?
Yeah, they can go higher than that. 10, 20. Yeah, some patients with post-transplant can elevate their lactic acids. I've seen high lactic acids.
Have you ever seen a INR of 27?
I can't remember that, but I mean, that's high. That's super high.
I believe she had a INR of greater than 27. Did you see that?
I saw that in the transcripts from Dr. Hudson, and I mean, I don't remember where that is now, but that's in the record.
Okay, and you saw that it was so high that the medical team in the hospitals had to call back to make sure that the reading was correct.
I'm aware of that, those interactions, yes.
When you have a INR of that, with that score, is that further indication of severe liver damage?
Yes, something like that is, there's no question.
And is it, certainly that's in excess of the 1.3 that you included in your slide number 19.
I think that should be 11.3, which is what another INR that she had, but she had an INR of 11.3, and then she had the other ones that you mentioned.
Okay, so this was a mistake in your slide number 19?
It looks like that needs to be corrected.
No worries. Is it also fair to say that Ms. Land Van Buren had evidence of fatty liver based upon the CT scan?
Yes.
Let's go to Ms. Diaz. I believe that's the next one, correct?
Yes.
So Ms. Diaz had a pneumonia level of 22. Did you know that?
Yes, sir.
Is that high?
It's high.
Is that an indication of liver injury?
Yes, this lady was an acute liver failure also.
And is it fair to say that her pathology report indicated that she suffered from hepatic necrosis as well?
Yes.
Which means that she suffered the death of liver cells, correct?
Yes.
She also had an elevated INR, correct?
She did.
And again, with her, as well as Ms. Land Buren, Ms. King, and Ms. Bordenave, without subsequent biopsies, you cannot rule out that they've all suffered permanent injuries, correct?
Correct.
Let's go to the next case, plaintiff. And that's Ms. Chang, I believe.
Yes,
correct.
Correct.
Let's take one step back in terms of Ms. Diaz. Do you recall Ms. Diaz having a biopsy that revealed regenerative nodules?
I'm aware of the regenerative nodules in the report, sir.
Is that an indication of some form of cirrhosis occurring in Ms. Diaz's liver?
I think it's an indication of how the liver, I mean, assuming that they're there, that's how the liver healed and it formed those nodules. I mean, there's a lot of debate about these nodules, but they can form with injuries, and livers can form those nodules in a haphazard way. It doesn't mean that there's cirrhosis. I mean, she doesn't have cirrhosis on the biopsy report, so there's a discrepancy there.
All right. And certainly you're aware of the fact that Dr. Datnow believes that that's an indication of cirrhosis, correct?
Yeah, I mean, Dr. Datnow has his opinion. If you say so, that's what his opinion is, yes.
Okay. And you're aware of the fact that in addition to Dr. Datnow, Dr. Hudson's has reviewed and had determination that there was some form of cirrhosis occurring, correct?
I'm not sure, but I mean, the biopsy doesn't show cirrhosis, so I don't know that I agree that she has that. You're asking me for my opinion. Some of the experts may have a different opinion.
What you can agree to is that she had some form of permanent liver injury that resulted in these regenerative nodules, correct?
That I cannot rule it out?
That's right.
Correct, I cannot rule it out.
Now let's go to Ms. Chang. So Ms. Chang had also a high lactic acid score. Did you see that?
Yes.
12.39. And in fact, instead of using the letter H for high, it's an exclamation point. See that?
Yes.
Have you seen the use of the exclamation point before in scoring?
I never paid attention to it, but I mean, I don't have a comment about that. It's a high level.
Okay. Again, further indication of permanent injury, of liver injury, correct?
Yeah, I mean, it's an indication of the acute liver failure situation.
Yes. And then if you were to look at the impressions of her CT scan, it showed severe fatty infiltration of the liver, correct?
CT scan mentioned that, yes.
Based upon your review of Ms. Chang's medical records, is it fair to say that she suffered acute liver failure that you cannot rule out has become permanent, correct?
Correct.
Next, Nigel Davis Richard. He suffered again acute liver failure, correct?
He was treated for confusion and encephalopathy by treating providers, so you can say that he was an acute liver failure.
Well, in fact, the medical records indicate that he meets the criteria for acute liver failure, correct?
That's correct.
He also had elevated pneumonia.
Yes, he did.
In terms of Mr. Davis Richard, did he have a biopsy?
I'm not aware of. No.
And because he has not had a biopsy, you cannot rule out that he suffered permanent liver injury, correct?
Correct.
And Mr. Mano is next. Did Mr. Mano also, by virtue of a ultrasound, show fatty liver?
Yeah, I mean, fatty liver sparing, I know it is. He has a hyperechoic liver, so it's abnormal echogenicity.
Yes. And is it also true that in terms of Mr. Mano, you cannot rule out that he suffered permanent liver injury?
Correct.
Ms. Nally is next, I believe, is that correct?
Yes.
Ms. Nally's CT scan of her abdomen showed fatty infiltration of her liver, correct?
Yes, it did.
Did you find it to be a moderate form of hepatic steatosis or fatty liver?
I don't know. I mean, it's both in the ultrasound and the CAT scan. It's a fact.
Yes, sir. Again, with Ms. Nally, you cannot rule out that she has suffered permanent liver injuries, correct?
Correct.
Doctor, with all of these patients, would you agree that they all, as a part of their treatment, have suffered emotionally going through acute liver failure?
Yes, they have.
And certainly that suffering stems from the confusion that goes along with acute liver failure, correct?
It comes from them being so sick.
Thank you. And with them being so sick and not knowing whether or not they'll have future problems with their liver, do you believe that there's a form of continuation of anxiety that goes along with that?
Yes, I believe so.
And that's in your opinion, having dealt with patients, that's an emotional, mental problem that they'll have to deal with the rest of their lives.
Yeah, I mean, each one is going to deal with it differently.
Yes, sir. Fair enough. And are you aware of the fact that these patients have been diagnosed by a neuropsychologist with a variety of emotional or mental issues?
Yes.
And would you agree that in dealing clinically with patients who have suffered from liver injuries, that's reasonable in your experience?
Okay, that patient with acute liver injuries, can you rephrase it, Mr. Parker?
Sure. And specifically, I'm talking about patients who have suffered permanent liver injuries and are required to go through these monitoring tests annually. That it comes with a certain level of emotional strain and anxiety.
Yes, I mean, I'm not putting myself in their situation, but I'm sure that they go through that.
And would you believe that it's reasonable for them to receive some kind of mental assistance, medical mental assistance from a psychologist or a psychiatrist or some form of physician who can address those concerns?
Yes.
I think that's all I have. Thank you so much.
You were asked about possible permanent liver injury. You recall that?
Yes.
In your opinion, any of these 8 plaintiffs, have they suffered a permanent liver injury? More likely than not.
More likely than not, I don't think so. I don't think so.
In your opinion, is there a likelihood that Ms. King will need a liver transplant in the future?
I think it's highly unlikely.
Okay. Is there a probability that Ms. King and Ms. Bourdnave will suffer an autoimmune hepatitis relapse in the future based on your medical opinion?
Is it probable? More likely than not that I think they're both over the episodes. I think it's unlikely. So I think that's unlikely to recur based on the fact that they're really like autoimmune cases.
Okay. In any of the 8 plaintiffs that you reviewed in this case, did you identify any evidence of cirrhosis?
None of them.
Okay. In any of the cases that we've been here talking about today, did any of those individuals die?
No.
Have any of those individuals undergone a liver transplant?
No, sir.
Do any of those individuals, to your knowledge, have a liver transplant scheduled?
No.
For all 8 plaintiffs, the most current medical records you've reviewed, are they within normal limits for their liver function tests?
Yes, that's accurate.
You were asked some questions about hepatic necrosis. Do you remember that?
Yes.
Okay. In your experience, is that a permanent condition?
Hepatic necrosis is how the liver responds to the injury. I mean, the cells have to die, and then cells regenerate, and they don't keep dying unless you have some toxin going on continuously, whether it's alcohol or a drug or something.
Is the liver capable of regenerating itself if it's undergone an episode of hepatic necrosis?
All this liver is regenerated to some degree. I mean, they regenerated from their injury and they form new cells. Otherwise, the patients would not have recovered.
You asked some questions about Ms. Land Van Buren, and you testified that she had suffered a severe liver injury. Is that correct?
Yes.
Okay. And to a reasonable degree of medical probability, is it your opinion that that is a permanent injury to her liver?
I don't think it's more likely than not. They may have some changes that we're not aware of microscopically, but otherwise their livers are working.
The questions that Mr. Watson just asked you related to DILI versus AIH versus DIALH. You understand the differences, correct?
Yeah, I think the consensus is that this DILI, like AIH, is the new term that should be used, and the other one is the idiopathic autoimmune. There's a lot of debate about how these things are going to be called.
And from the literature, I recognize that there's a debate in terms of AIH versus DILALH. So autoimmune hepatitis versus drug-induced autoimmune-like hepatitis, correct?
Yeah, there's debates on different fronts. veins, pathologies, etc.
Microscopically, there's no difference you can tell between AIH and ALH, correct?
They're difficult to differentiate, yes.
Same with symptomology, correct?
Similar.
And so when Mr. Watson was trying to ask questions to determine whether or not there's any permanency to these plaintiff's injuries, he was asking you to make a decision or give an opinion based upon your experience and the literature, correct?
Yes.
But he was asking you to do so based upon the bulk of the literature and your experience dealing with drugs not including hydrazine, correct?
Right, the hydrazine has not been looked at in any of these registries.
Right, and so when you responded to Mr. Watson, your response was based on not hydrazine-specific literature, correct?
Yes.
Thank you. Because the bulk of your career, with the exception of the 50 or so patients you've seen, or records you've seen, I should say, did not suffer acute liver injuries based upon hydrazine, correct?
None of them in my career, correct?
That's right. And based upon the information you've read from, for example, or the reports you've read from Dr. Robin, he has not had any experience dealing with livers injured by the consumption of hydrazine, correct?
Correct.
So when you give an opinion based upon the permanency of the injuries for these patients or plaintiffs, in this case, the 8 that you reviewed, really the best history or the best authority we have on the subject is that hydrazine can kill, it can require liver transplants, and it can cause permanent injury to livers, correct? Human livers.
Yes.
And because there are no up-to-date biopsies, you cannot say that all 8 of these plaintiffs have not suffered permanent liver injuries for which they will need medical care in the future, correct?
Correct.
And then finally, when Mr. Watson asked you about follow-up care, because there's so little literature and so little experience from the hepatology world on hydrazine and how it affects the human liver, is it fair to say, and is it medically reasonable, that all of these patients should be followed to make sure that they don't suffer any further liver injuries, correct?
They should be followed. I agree with that.
And based upon the limited articles we have, it indicates even if they appear to be normal, their symptomology has been resolved, there can still be a progression of liver injury associated with hydrazine, correct?
Sure.
And you give all those opinions a reasonable degree of medical probability or certainty, correct?
Yes.
Nothing further. Thank you, Doctor.
That's the end of the deposition, Your Honor.
Okay, thank you. Can we approach, please?
Just for clarification, that was not a deposition. That
Trial
was
deposition.
Trial testimony.
Trial testimony taken outside court.
Okay, ladies and gentlemen, it's my understanding it's time for lunch.
Appreciate it.
And a couple of things, I just want to let you know before we break, council's gotten together and they provided lunch for you. And that'll be in the jury deliberation room. Is that correct, sir?
That is correct, Your Honor.
All right, just want to let you know that. Secondly, at this point, does the defense rest?
It does, Your Honor.
Okay. And so my point is this, we're making a lot of progress. I just want to let you know that. And so at this point, will there be any rebuttal from the?
No, Your Honor, we're going to waive rebuttal.
All right. So we're done with the evidentiary portion of the case, just to let you know that. Nonetheless, there are certain things we have to do. And so we're gonna break right now until 1:30. I will have, at that time, I will meet with counsel. I might have a couple of things to go over them that shouldn't take too long. But I just want to let you know what's going on from a trial perspective. You understand that? Okay. Did I miss anything, counsel?
No, Your Honor.
Okay.
No, Your Honor.
All right, so remember, you're admonished not to converse amongst yourselves or with anyone else on any subject matter connected with this trial, or to read, watch, or listen to any report or a commentary on the trial by any persons connected with this case, or by any medium of information, including without limitations, newspaper, television, radio, social media. Remember the prohibition. And last but not least, you're not to form or express any opinion on any subject matter connected with the trial until the cause is finally submitted to you. I can say this, when we first met, I guess probably about a month or so ago when I came down to meet you, and we talked about how long it was going to take to try this case, we're definitely within the schedule. I can let you know that. We'll be done before time. Exactly when, I'm not 100% sure, but we'll be done before Friday. Is that safe?
By Friday for sure, Your Honor.
By Friday for sure, just to let you know. So I wanted to make sure you understand where we stand, because you've made a significant commitment and you've taken time out of your life, and the lawyers really respect and appreciate that. Their clients do. And also from a justice perspective, as a trial judge, I really appreciate it, because as we talked about, the system would not function without the citizens, we the people, willing to commit their time. All right.
All rise for the departure.
I just gotta turn these in. Yeah. We can make the Sands motion first.
Your Honor, may I approach with the original?
Oh, you sure can.
Curious,
And these are original deposition transcripts?
These are
For Dr. Alcina.
Yep, so I guess we go to lunch, right?
You guys really want to do their Sands motion real quick?
Okay. Yeah, we have to be efficient as we can.
May I proceed, Your Honor?
Yes, you may, sir.
Your Honor, we filed a trial brief to strike plaintiff expert Dr. Stephan Sand's testimony regarding future psychological damages. No counsel has indicated their position. This has been previously argued. It's not. Dr. Sands testified at trial regarding certain of the plaintiffs in this case suffering psychological damage as a result of being exposed to real water with hydrazine in it. Basically, his opinions were twofold. Number one is he did a series of psychological testing and interviews with the individuals and came to opinions in that regard. That isn't the point of our motion. What became evidently clear is that Dr. Sands was going to, as we stated early on in the case, basically give a cookie cutter opinions regarding each and every one of these individuals' future care needs as related to their psychological or psychiatric care in the future, and came up with a monetary number that he believed that they would have to incur that expense for the care that he thought they were going to need. However, Dr. Sands admitted that that wasn't his opinion. His opinion is that, yes, he believed that each of these, it was likely they were going to need care, and gave a number up to a certain figure. However, he made it very clear during his examination on the stand that these opinions were subject to each of these individuals going to be evaluated by a proper professional or psychiatrist or psychologist or neuropsychologist first, have that evaluation, and then have that healthcare provider provide the plan and those expenses. So it was that individual would have to come up and establish a recommendation under the treatment they would receive, and he said correct. Additionally, he stated during his direct examination that while it was his recommendation that they be seen by another psychiatrist, psychologist, the caveat was that he didn't know, it was, I'm trying to be responsible and leave it up to the other professionals, yes, and stated that some of these people may not need any help, correct? He said not likely, but yes. He also stated to the question, and it would vary plaintiff to plaintiff based upon what these other professionals would come up with in terms of a treatment plan, and he says sounds correct. It is undisputed. Not only did they not come up with a treatment plan individually from another healthcare provider as recommended by Dr. Sands, but didn't see anybody at all regarding a psychiatric or a psychological plan. And for that reason, they do not meet the burden in terms of being an assistance to the jury. His opinions are incomplete, admittedly so. And for that reason, any testimony as it relates to Dr. Sands' claims of future damages, the cost of that care should be excluded. Thank you.
Thank you, sir.
Yeah, Judge, I think Mr. Johnson says we haven't argued this before. That's almost word for word what he said 3 times. If you recall, he had Dr. Sands on the stand, and at one point, he turned to the jury and yelled, "I move to strike because it's speculative," and that's what led to the curative instruction and the lengthy sidebar, which we went over all this. All these exact arguments were made. There's only one change since that time, and that change is Dr. Alsina just testified, his expert just testified that all these plaintiffs need psychological care and that's reasonable for them to get it. So
I don't mind telling you this. I have right down here in my notes. Didn't Dr. Alsina just testify to that?
Yeah, so, Your Honor, there's no grounds for this motion. We ask that it be denied.
My response is that no doctor in this case has established, which the court has indicated previously, that it's up to the doctor to establish what the necessary medical expenses are. They can't be determined, they can't be guesswork, and that's what Dr. Sands admitted, and I'm fairly certain, although I was not here, I was at the deposition, neither did Alsina state what those costs would be. Again, Dr. Sands stated that the plaintiff's conditions were not identical, but they all had some form of psychological damages. And again, he states, it's not everyone had problems. It's not everyone that had the same problem. And he goes through each of these individuals had different problems as relates upon the diagnostic testing. So the fact that you have what they may need, etc., doesn't meet the standard. Additionally, I don't know how many times I have to say it, but I guess it bears repeating because counsel doesn't understand our argument, is that he cannot state with a reasonable degree of medical probability what the future cost of medical care for these individuals. Admittedly, he says that has to be done by another provider, which was not done in this case. Thank you, Your Honor.
Dr. Alsina said they all need it, Your Honor. Each and every one of them. That's what Dr. Alsina, his expert, said.
And having the final word, again, did you hear a number out of Alsina's mouth? No, you did not. That's not been presented, and it's not for the jury to speculate. Thank you, sir.
All right. And ultimately, when it comes to making a determination as to the need for future treatment and care, it doesn't have to be an exactitude. It has to be to a reasonable degree of medical probability. And we have testimony from, I guess it's Dr. Sands and Dr. Alsina as to the necessity for future care. And ultimately, whether or not it's needed, that's going to be up to the jury to decide. And so I'm going to deny the motion.
And the cost is up to the jury to decide as well, Your Honor?
Whatever the need for future treatment and care will be, they'll decide that.
Okay, Your Honor, thank you.
Yeah. Judge, the last issue was we tendered a life expectancy instruction for for Abraham. And the reason we did that is because he's the youngest plaintiff here. It says he's going to live for 59.6 or 4 years or something. And we didn't tender it for everybody, but we thought it was appropriate for him because of his young age, because he's going to have the permanent injury during this entire time period. That's why we tendered, and we think it's an appropriate instruction.
Any issue regarding life expectancy, they're pretty routine.
So
Your Honor, we actually asked for an explanation on Abraham several times over the course of the last 24 hours. This is the first we've heard of it. We've agreed to life expectancy jury instructions for Lisa King and Andrea Bourdonnais. Mr. Abraham obviously does not have the same conditions as those two, and we believe that including him individually as opposed to the other two is inappropriate given the nature of his condition. So we have been willing to reach a stipulation of including that jury instruction, but only including Lisa King and Andrea Bourdonnais accordingly. So really it just comes down to whether or not Mr. Olvera is included on the instruction as well.
Judge, their testimony is he's got permanent liver injury, which even their expert can't rule out. And we just want the jury to know he's gonna suffer that for 60 years. I haven't asked for the instruction for any of the other plaintiffs, because I don't think it's really germane. You know, King and Bourdonnais are a little bit different because they're getting expensive treatment on an annual basis. But Abraham, I think I'm entitled to argue to the jury that he's gonna go through this permanent injury for the next 60 years. And I don't really see what the big deal is, because, you know, I can also tell the jury he's 20, he's gonna live 60 years. And I could do that during close, but I think it'd be more appropriate for instruction.
Yeah, and Your Honor, we've made our point. So whatever the court wants to go with, we'll respect the decision, obviously.
Yeah, I mean, why would I not give a life expectancy for the minor child?
Well, you heard,
and see, here's the thing, and I've listened to all the testimony, and this kind of goes back to the discussion we had yesterday. I listened to Dr. Alsina, and he was pretty clear as to specifically what couldn't be ruled out, right? And he would, as far as future potential injury and the like. And the reason for it is this is such a unique case, and I understand from an ethical perspective why there was no human testing as it pertains to hydrazine and what impact it might have on the bodily organs. I get it. You know, you wouldn't do that because the state of the evidence is that small amounts in animals. We had the example with the one individual who was exposed to exhaust fumes from, I guess, the jet, and so on and so on. And here's my point. There's no studies out there that definitively talk about what the long-term results are when it comes to exposure to hydrazine. That's ultimately what it is. And so I'm going to take a cautious approach as far as the young man is concerned and permit his life expectancy, because we don't know. And the reason why we don't know long-term effects is, like I pointed out the other day, and I even think Dr. Alsina kind of mentioned this, the ethical problems there, because there's no testing. We just don't know. And to be really candid with everyone, I doubt there ever be any type of testing as far as it relates to hydrazine and what long-term impact or effects it has on humans, because we know it's deadly.
That's right.
And so I'm going to permit it. And he's a minor, and we don't know.
I'm sorry.
Go ahead, Mr. Parker.
I have one concern, given what Mr. Johnson said a little while ago. The court has already determined causation, which includes the injuries of our clients and their past medical bills, which Mr. Johnson put in front of the jury during his opening. My client's medical bills included her diagnosis of anxiety. So they've already been found responsible for those medical records, which included her diagnosis of anxiety. I don't believe that Mr. Johnson can get up and now say that Ms. Bourdonnais did not suffer anxiety, which was diagnosed in 2021 as a result of her consumption of real water. I think it would be seeking jury nullification. I think it's against the court's decision on February 10th. And I don't think that they can argue that point to this jury in terms of Ms. Bourdonnais. I put that out there, not that, I doubt I'll get to my closing today, or that Mr. Johnson will, but I don't think it's appropriate for him to argue that Ms. Bourdonnais didn't suffer from anxiety caused by real water, since it was a part of her diagnosis and medical bills, which have already been put in front of the jury and agreed to.
You know, what's funny is when counsel has weak arguments, it reverts to jury nullification. Our motion in this case, as it related to future medical care, was the medical specials that have never been proven up in this case. I can argue anything that is consistent with the facts that have been presented in this case, and there's no fact more evident than these individuals have not received additional care for psychological injuries they claim to have sustained, and there's no medical specials to back them up.
The medical specials included the anxiety, which is a part of the gastroenterology report that's going in front of this jury already, which included the $387,000 that you've already agreed to. So that's done.
Now the gastroenterologist is making diagnosis. That's never been presented as a cause of action in this case, Your Honor. It was Dr. Sands who saw Ms. Bourdonnais. It was Dr. Sands who was that expert. So I anticipate that I'll make arguments that are consistent with the facts and evidence that were presented in this case.
Your Honor, in fact, Mr. Johnson got up when crossing Ms. Bourdonnais and said, "You've never been diagnosed with anxiety until after your son came down with diabetes." And then I put on the screen Exhibit 154, page 28, showing that she was diagnosed with anxiety 2 years before her son had diabetes. That was part of the, excuse me, Mr. Johnson.
Sorry.
Typically when, I won't even address that, Mr. Johnson. But that was 2 years before her son was diagnosed with diabetes. And those are bills and medical services that they've already agreed to, conceded to. So, Your Honor, it's too late. That ship has already sailed in terms of her diagnosis of anxiety related to her acute liver failure and autoimmune hepatitis.
Your Honor, she testified in her deposition subsequent to the gastroenterologist restating that she was anxious due to her condition because she was being moved from hospital to hospital, testified in her deposition that the extent that she has any anxiety and is on anxiety medication, she said definitively under oath it is unrelated to real water. She confirmed that testimony on the stand.
Your Honor, I don't know why he's conflating anxiety and being diagnosed with anxiety, or anxious and being diagnosed with anxiety. She was diagnosed with anxiety. That medical record was stipulated to and went in front of the jury. It was in 21. The question he presented during the deposition dealt with her feeling anxious after her son was diagnosed with diabetes, not in 2021. Additionally, Your Honor, which I don't know why Mr. Johnson keeps trying to confuse the issue. The moving from hospital to hospital was a result of her acute liver failure and autoimmune hepatitis. She went through 7 hospitals. I can't remember exactly the number of ambulance rides and flight for life, but certainly that all came with anxiety, which Dr. Alcina said was reasonable, Dr. Hudson said, and Dr. Sands. But the main thrust of this request, Your Honor, is they've conceded this already. This is a part of the medical bills that Mr. Johnson put up in his opening. So that ship has sailed, like I said before, and the court determined.
Are we going to argue that if you're exposed to hydrazine resulting in, I guess, the constellation of physical symptoms and ailments and the diagnosis in this case regarding the plaintiffs, that they didn't suffer some form of anxiety?
That, Your Honor, again, they don't have an expert, so this is all argument on their part. And they're trying to find some way of now getting out of their own concession on the exhibit, their concession on the medical bills put in front of this jury, and the admissions made by their own experts. That's what they're doing. But the order of the court stands as of February 10th. All medical bills, causation to all medical injuries. This included the diagnosis of anxiety in 2021. And they've never disputed that. So now they're upset with the consequences.
I just asked a general question, or are they saying that under the facts, understand this is a very unique case. Under the facts of this case, and as a result of being diagnosed with a constellation of different diagnoses in this case regarding the plaintiffs, and the known impact hydrazine has on the liver, is the defense taking a position that they didn't suffer anxiety?
No, Your Honor, I'm not. I'm taking offense to the fact she testified in her deposition on the stand that the fact she's currently receiving anxiety medication relates to her son's diabetes, has nothing to do with real water. I'm not going to be able to state that.
No, I'm just asking you the general question. So your position is that based upon her deposition testimony, that she had no anxiety as it relates to her exposure to real water.
I said that in my opening, Your Honor, that she had to go to the hospital, and she didn't deserve to have that. But it doesn't, we don't get to whitewash the fact that currently her issue related to anxiety is with her son's diabetes. She didn't testify only that in her deposition, she testified it on the stand.
Your Honor, he's trying to circumvent the court's question and run away from the fact that she was diagnosed with anxiety long before her kid had any diagnosis of diabetes, and it was related to what she had to go through with following her consumption of real water. Autoimmune hepatitis diagnosis.
Yeah.
And
Here's
7
my point,
hospitals.
though. We can have more than one reason for anxiety.
Sure you can, Your Honor.
Yeah, but I mean, and I'm quite sure there was anxiety as a result of her son's diagnosis. Okay, that's fine. But are we going to argue that she had no anxiety? In this case, that would be compensable under general damages.
Thank you, Your Honor.
That's what they're rambling about. I've never said that. I'm saying
Just don't say it in closing.
Oh, I'm going to say it in closing, Your Honor.
Well, then we're
I'm
gonna have an
repeat
issue.
what she said on the stand and in her deposition in closing.
Judge, he can't get up and say that she was not diagnosed with anxiety as a result of her real water consumption. And if he does, then that's against the court's order. It's against the concessions made already in terms of the medical bills which covered that anxiety diagnosis.
All right. Is there anything else? Because,
Nothing else, Your Honor.
I mean, ultimately, this case is unique. The hydrazine exposure it appears to be, and based upon the evidence, very serious. Dr. Alsina admitted that. And my point is this, the court orders are what they are. The evidence is what it is. And I would just hope that we would proceed accordingly.
Thank you, Your Honor.
That's probably the best way to say that.
Judge, there's one little minor issue on the jury instruction that I forgot about. I thought it was just the one thing. They have an instruction that we think is duplicative of another instruction.
May I approach, Your Honor?
Yeah, what's the other instruction?
This is our defendant's proposed instruction, Your Honor, based on Morse Code. And that's actually the language from Morse Code.
Judge, we do have an instruction on page 31. It's a stock instruction from the 1989 approved pattern jury instructions.
1986, you mean?
Oh, 1986, yes, Your Honor, sorry. Whether any of these elements of damage have been proven by the evidence is for you to determine. Neither sympathy nor speculation is a proper basis for determining damages. However, absolute certainty as to the damages is not required. It is only required that plaintiff prove each item of damage by a preponderance of the evidence. That's the law, that's the jury instruction. That is, the proposal is duplicative and it perverts, I think, what the correct statement of law is.
And Judge, we would object to that. That's a special that they pulled out of the Morsicata case, so we object to that.
That has to do with admissibility of expert testimony.
Oh, I remember the case. It was in front of Judge Earl. And I remember exactly what happened in the case.
That was our case, Your Honor.
I know it was. I know it was, and unfortunately, the expert didn't testify to the level that was necessary.
Well, and Your Honor, that's kind of the point. We've heard a lot of argument today about experts in this case that are opining below the standard, whether that's the mere possibility that something could happen in the future, whether or not that it's relying upon another expert who has to provide an additional opinion after this case is over. And the defendants need to be able to remind the jury specifically and narrowly that their damages have to be provided, their compensatory damages have to be provided based upon anything that is, more likely than not.
Tell me this, why wouldn't, and I don't mind saying this from a historical perspective, we can go back 19 years, and I've been very clear. as far as I handle jury instructions. And every case that's been tried in this department, as a foundation, I've always followed the 1986 pattern jury instructions. And there's a reason for it. Take a look at the forward, and it's the only set of pattern jury instructions we've had that have been approved by our Nevada Supreme Court.
That's right.
That's it. And I always, every case, there's not one case, in fact, I've had many cases where the two binders, and I forget the years, that have never been approved, have been proffered, and I said no, right? And so why would I give this on top of the pattern jury instruction as set forth? And I don't have my book right in front of me, but
Your Honor, if it helps, we're not contesting the pattern jury instruction.
that's not my question. My question is, why would I give this on top of? And here's my point, because I don't have my pattern instruction right here in front of me from the blue book, but what instruction was that again? Because we have all these on,
It's 10.19.
1019. I keep my book hidden because they're hard to find.
Right.
1013?
10.19.
1019.
Your Honor, if it helps,
Oh, I have it right here.
no, my point is, if it helps, I think I know where the court is going. We've just asked that the proposed instruction be lodged for the record, and then we can move along.
Okay, no, I understand, but my question was real simple, because I am looking here at jury instruction, pattern jury instruction, 1019, and, yeah, I put it, I keep it hidden in a safe. But I'm looking here, it says, quote, whether any of these elements of damages have been proven by the evidence is for you to determine. Neither sympathy nor speculation is the proper basis for determining damages. However, absolute certainty is not, as to damages is not required. It is only required that plaintiff prove each item of damage by a preponderance of the evidence. That kind of covers it all.
So if
Right?
I understand the court's ruling, Your Honor, we are going to exclude that instruction, lodge it for the record.
And we can do that, but there's a reason why I'm going to exclude it, is because, not because I don't want, just because this is what I want to do, but it's duplicative of 10.19 in that it clearly states, it actually goes further. Neither sympathy nor speculation is the proper basis for determining damages.
Understood, Your Honor. Thank you.
Yeah.
And Judge, the only other issue, as I mentioned earlier, is we both tendered competing verdict forms, so we need a decision on which one we're going to use.
Okay. And I'll take a look at those. And here's my question as far as verdict forms are concerned. Why wouldn't I use the same verdict form I've used in the other trials?
Judge, that's our position, and if you recall, Real Water agreed to that the verdict form was ever trial.
Respectfully, Your Honor, whatever Real Water's prior counsel did is immaterial. This, again, I'm I
get that.
Sure.
No, but that wasn't my question. My question is, why wouldn't I use the same form? Because I vetted that.
Your Honor, there are jury instructions in this case that specifically admonish the jury that they are to treat each individual plaintiff as its own case. By segregating out the verdict form by plaintiff and by the set of damages, we are reinforcing with the jury that they need to take a look at past pain and suffering, future pain and suffering, medical expenses, and provide a total and evaluate this case independently based on each individual plaintiff's case. That's what the jury instruction that's been stipulated to by the plaintiffs says. That's what the jury is going to be tasked with doing. And so the defendant's proposed jury verdict form promotes that particular analysis of the case, as opposed to simply slapping all of the plaintiffs down on one page and asking for a broad strokes total. So that would be the defendant's position, Your Honor. And again, to the extent the court is inclined to go with the old one, we've just asked that it be lodged for the record.
Okay, I got you. Anything else?
No, Your Honor.
I'm going to take a look at them.
Okay, thank you.
All right. We're done.
All right.